Okay, so welcome everyone to this evening's LSL LSL meeting. What we're going to be doing today is talking about our new macular surgery pathway. I'd like to introduce Mr. Luke Michaels, newly consultant at Thomas's. I got that title completely wrong, didn't I? He's going to be our guest speaker today. We are very, very lucky to have him. He's going to be introducing us to this pathway. So over to you, Luke.
Thank you very much. I'm sorry, I'm just going to restart the presentation because just to help me keep to time, not keep you too long this evening. So thank you for the introduction, Bavina. So yes, this evening I'd like to introduce you to our new direct macular surgery pathway that we're offering at St. Thomas Hospital. It's a pathway aimed at treating vitreomacular traction, epiretinal membrane, and full thickness macular holes. By the end of this evening, I'm hoping to be able to demonstrate and do some teaching on the mechanisms by which the age-related vitreous changes and PVD lead to all the tractional proliferative macular pathology that we see. We'll go through some OCT patterns of common conditions and how to recognize them, go through when to refer and when to monitor, and link all of this with the College of Optometry clinical management guidelines. I'll touch upon some of the stuff that we do at the hospital, secondary care management, talk you a little bit through the patient experience, and go through some surgical videos. So the clinical management guidelines by the College of Optometrists can be found online and on the app. And today we'll be going through these two main topics, idiopathic epiretinal membrane and vitreomacular traction and macular hole. So just to outline the new service, the direct macular surgery pathway is a rapid access service for treatment of
Join this webinar now, CMG. Good evening.
It starts off in primary care where community optometrists identify vitreomacular conditions such as vitreomacular traction, epiretinal membrane, and macular hole. They're referred through the ERS system to the single point of access team, who then can divert patients to the direct macular surgery pathway. Patients are seen in our virtual diagnostic clinic and have a consultant review within 3 weeks. The aim is for patients coming through this pathway from start to finish to have their surgery completed within 3 months, particularly for macular hole, as there's good evidence that having surgery within 3 months leads to better outcomes. What we've identified across the region, sometimes patients are referred in, they might be seen in a timely fashion, but they end up sitting on a waiting list and not having their surgery in the due time that we'd want them to have it. So a bit of guidance that comes from the Department of Health and Social Care. Patients should be should have a right to start treatment within 18 weeks. Since the COVID pandemic, this hasn't really happened across NHS. There's been massive backlogs and patients haven't been getting their first appointment within 18 weeks. There are targets set by the government to try and bring things back to where they were in 2015. I'm pleased to report since the introduction of our new pathway and the vitreoretinal service at St. Thomas, we've managed to bring our first appointment rate from 65% up to 90%. So we're well on target. Now, the Department of Health also set out some plans on how to address the backlog and to offer people more appointments. And one strategy is the implementation of surgical hubs. Surgical hubs are basically one-stop shop clinics where patients with a specific subset of conditions receive a diagnosis and treatment within a dedicated service that just deals with that, allowing faster productivity and outputs. But that's quite tricky to implement in a vitreoretinal service. You may be aware that most of our work is emergency work dealing with retinal detachment, whereas vitreomacular pathology is a main component of our elective work. So what we've done is basically decoupled our elective work from our emergency work and tried to set up what we call a macular surgery hub, which is a dedicated hub dealing just with these vitreomacular pathologies. We can do the surgery very quickly, achieving very high output, similar to what's been done in the past with cataract surgery. The pathway all starts off in primary care with community optometrists identifying the conditions that we need to treat. And through the course of the evening, I'm hoping to go through some of these conditions and help you identify them. So we said the patients identified, they referred to our virtual clinic. Within 2 to 3 weeks, they attend our virtual clinic in Minikid House. That's based in Clapham. The nearest station is Clapham South. It's a very quick appointment. Patients come in, have a visual acuity assessment, followed by an OCT scan and an optos, reducing waiting time in clinic. They then have a follow-up the next week with a consultant who will then go through the findings of the scan and list them, if appropriate, for vitreoretinal surgery and plus or minus cataract surgery as required. And we do this all through our new electronic patient record. Patients are able to download the Epic app and we can send them all the information, leaflets and consent forms relevant to the procedure all through the phone. So the patient's first interaction with us really is when they come to surgery at St. Thomas's Hospital. Patients really like our ophthalmic day case unit. It's up on the 8th floor and they get a lovely view of the London Eye opposite us. Many patients come fearing having vitreoretinal surgery, but with new technology and a new instrumentation, it has become a very quick and safe operation. For a patient with a PVD who's pseudophakic and an epiretinal membrane, we can do surgery within half an hour, which often surprises patients. The complication rate from surgery now with vitreoretinal surgery is extremely low, probably in the region of 1%, which is less than cataract surgery. So from the patient's experience, once they've come to the ophthalmic day care unit, they then move down to theatre. This is one of my colleagues operating with our 3D visualization system. They have some numbing drops in to numb the eye. They're then covered with a drape. We put a little clip in to hold their eye open and give them an injection around the eye. This is often the most unpleasant part of the procedure. It stings for a couple of minutes, but beyond that point, most of our patients find it very comfortable. The anesthetic numbs the pain fibers, but it also numbs the optic nerve, which takes the pictures essentially. So patients won't see instruments coming towards them or anything like that. At most, they might see some colors or some movement. And we've done some research, some service evaluation at St. Thomas's, looking at patients' experience, and most patients report a 2 out of 10 discomfort with the surgery. They all report that it's better than the dentist, and you'd be surprised how many patients fall asleep while they're having it done, and I have to tap on them to wake them up. So going back to primary care, identifying these conditions, it's always, in order to identify these conditions on OCT, we have to go back and look at our basic OCT anatomy. Rather than labeling 50 shades of gray here on the OCT, I always find it helpful to look back at these diagrams which superimpose the different cells that compromise the that compose the retina. So starting out from the outer layers, we have the RPE. That's the first bright line that we see on an OCT scan. This is followed by the interdigitation zone, the connection between the RPE and the photoreceptors. So the next bright white line. The next line after that is the ellipsoid zone. It's thought that the mitochondria that are within the photoreceptor body is what gives this bright line on the OCT. We then have some dark gray layers, the cell bodies of the outer nuclear layer. Then we have the outer plexiform layer, which is the connection between the inner nuclear layer cells. The inner plexiform layer is the connection with the ganglion cell layers. And then the fibers from the ganglion cell layer form the retinal nerve fiber layer, which goes off to the optic nerve. Now, behind all of this is a cell that doesn't get much mention, which is called the Macular cell. The Macular cell is hiding behind here, and it's a cell that crosses the whole length of the retina. And its distal part, the distal foot plates, form the ILM. The Macular cell is actually a much larger structure that provides support to all the other cells within the retina. Beyond its support function, it's also thought to help in transduction of light to the photoreceptors. In the inner aspect of the Muller cell, there are these cone or funnel-like structures which funnel the light like a fiber optic cable all the way down to the photoreceptors. These funnel-like structures together in the center of the retina and the fovea join together to create something called the Muller cell cone. I'll just move this out of the way. The Muller cell cone is like a hub-like structure which holds the fovea together. And it's an important structure to be aware of, as during PVD, this structure can be pulled out of the retina, resulting in some of the vitreomacular pathology that we see. So going back to all these conditions, the root cause for most of the pathology that we see is PVD. This is a really good video made by Cam Balagan, who's a vitreoretinal colleague at Wolverhampton. You can find the video on Optometry Today, how to identify PVD. So PVD starts with detachment of the perifoveal vitreous, which we call stage 1 PVD, whilst remaining attached at the fovea. It then progresses to detach from the fovea and involves just the posterior pole. It then extends, remaining attached to its strongest adhesion point at the back, which is the optic disc, and finally detaches from the optic disc, creating a vice ring. So, starting off with the most commonest pathology that we'll see, epiretinal membrane. Epiretinal membrane is an extremely common condition. 15 to 20% of people at the age of 70 have one. That's 1 in 5 people at age 70 have one. This rises up to nearly 1 in 3 people at age 80. Epiretinal membrane isn't always a problem. What is epiretinal membrane is thought to occur after PVD. You get a sprinkling of hyalocytes. Those are the cells that compromise the vitreous that stay on the surface of the retina. And then they go through a change. They turn into myofibroblastic cells, which basically have a contractile property, creating a membrane that scrunches at the retina, causing crease marks. I often say to patients, those crease marks, imagine a scrunching up a sheet. Those crease marks means that the retina is no longer straight. The bendiness or waviness that you find on the sheet is what gives patients the symptoms of metamorphopsia or distortion. The shadowing, they sometimes get monocular diplopia, and the images can look different between the eyes. Surprising, well, it may not be surprising to you, many patients are completely asymptomatic and completely unaware of it when it affects the non-dominant eye. 90% of epiretinal membranes are idiopathic, thought to be secondary to PVD. But there are secondary epiretinal membranes, and those can be caused by multiple things, such as retinal detachment, trauma, bleeding in the eye, lasers, uveitis. Many pathologies of the eye can lead to epiretinal membrane. The pathways are common. As I mentioned earlier, the hyalocytes go through some changes through cytokine release and growth factors, turning into a myofibroblastic contractile membrane. To treat the condition, which is I'll just show you here on the OCT scan, the membrane covers the surface of the eye, creating this white line on the surface here. To treat the condition, we just simply need to remove it. This is a quick video of an epiretinal membrane peel. It's a very satisfying procedure to do when it's as good as this. Sometimes the sheet can come off in one go. This video isn't sped up, it's real-time speed. With tiny forceps, we grasp the membrane on the surface of the retina and pull it away and peel it, releasing all the traction on the retina, which is causing the patient all the symptoms. On the right here, we've got a picture of a patient who's come through this pathway, who presented with an epiretinal membrane, that's been peeled off. When we offer vitreoretinal surgery, we'll usually combine it with cataract surgery for every patient over the age of 50. As most patients over the age of 50 have a component of cataract, And with vitreoretinal surgery, it will only get worse. So we do the cataract surgery as part of the vitreoretinal surgery to save them a second operation. The College of Optometry guidelines talk about the Gobetto classification system. It is useful for research, clinically day-to-day, maybe a little bit less so. Basically, you need to recognize stage 2, and anything beyond that is not too important day-to-day. So I'll talk you through the stages. So stage 1 epiretinal membrane is when the epiretinal membrane grows on the surface of the retina. Stage 2 is when we get a change to the foveal pit. The normal dip that we see at the fovea is lost. Stage 3, the inner layers of the retina start to cross the fovea. And stage 4, we get disorganization of the retinal layers. It's not, vision doesn't strictly follow this pattern, but it gives you a good indication of what to expect. The higher the stage, the worse the vision you'd expect. Now, essentially what you need to know day to day is if there's a change in the fovea, 30% of those patients will then go on to require surgery. So anyone who's a stage 2, where you've lost your foveal pit, might develop surgery. At stage 1, these patients usually have excellent vision and we're not worried about it at all. Vision isn't the best marker for examining or stratifying these patients because often they come with concurrent cataract, and vision alone isn't the best marker to define or classify an epiretinal membrane. Another thing that we look at on OCTs is abnormalities of the foveal bouquet. So what happens is when you have a PVD, the gel pulls on the Muller cells, as we mentioned before, leading to a change in the photoreceptors. We see that on an OCT scan as a fuzzy patch, and we call that a cotton ball sign. As traction from the ERM progresses, you then get subretinal fluid developing, which can eventually result in a vitelliform lesion. Now, the prognosis, if you do go through all of these stages, is slightly guarded. Post-surgery, these do disappear as you relieve all the traction from the epiretinal membrane. It's not a hard sign, but it's something that's useful to guide patients through the prognosis that we'd expect. If you can see some fuzzy patches right at the fovea, the prognosis might be not as good as if it wasn't there. So epiretinal membranes, as we mentioned, contract. They cause crease marks on the retina, but they can cause other changes to the retina structure. The membranes can pull the retina outwards or pull the retina inwards. When the retina is pulled outwards, it can unzip, causing a schisis. This is called ERM with foveoschisis. So the membrane is contracting, pulling the retina outwards, unzipping the inner retinal layers, creating this schitic appearance. When the retina is pulled inwards, you end up with a very sharp edge to the retina, almost like looking down off a cliff into a crevice. We call this pseudo hole. So that's how I identify a pseudo hole. I imagine if there was a little man sitting on the edge of the hole there, if I can see all the way straight down to the bottom of the crevice, that's a pseudo hole. Both of these conditions, ERM with foveoschisis and pseudo hole, tend to maintain, patients with these conditions tend to maintain really good vision because all the tractional changes are affecting the inner layers, whereas the photoreceptor layer, which is detecting the light, remains largely unaffected. Lamellar holes. Lamellar holes are partial thickness holes which don't go through the full thickness of the retina. They used to be all clumped together, but now we split them into two. Lamellar holes can be tractional or degenerative. Tractional holes are essentially ERM with foveoschisis. You've got traction from the ERM causing a splitting of the retina. A true lamellar hole is a degenerative hole in which, for some reason which we don't quite understand yet, you lose Muller cells, and then they then go through a change which we call epiretinal proliferation. The Muller cells grow over the surface, the exposed surfaces onto the surface of the retina, giving this very thin, bright line, which we call epiretinal proliferation. So unlike epiretinal membrane, where it's thought to be primarily hyalocytes, which are growing, giving you that thick white band, in lamellar holes, you get this epiretinal proliferation, which is mainly composed of Muller cells, giving you this very thin membrane on the surface. Why is that important? It's mainly important for the surgeon treating the condition. Lamellar holes then tend to progress. Only about 10% of patients will progress over 4 years, losing about 2 lines of vision. In epiretinal membrane, as I mentioned earlier, we just peel the membrane off the surface of the retina. But in lamellar holes, because the Muller cells are continuous with the Muller cell structures in the center, if you pulled it off, you'd actually cause trauma to the center of the retina, potentially resulting in a macular hole. The Muller cell epiretinal proliferation has a yellowish color to it through keratins that are that it's composed of. So we peel it, leaving this foveal crown, which we then push into the defect to seal it. As I mentioned earlier, lamellar holes don't normally need surgery, but we will offer surgery to patients who are very symptomatic in terms of distortion. These pictures here are from a patient who I've treated in our clinic. This patient was a wildlife photographer, and he had this problem in his dominant eye, and he was finding it very difficult to use the viewfinder in his camera. So he came in with a partial lamellar defect, which progressed, unfortunately, into a full thickness hole. We offered him the surgery. You might notice the white line on the surface here, that's epiretinal proliferation. We've peeled that off, filled the gap. It's now closed. This is a post-op picture, and he's retained 6/6 vision and resolution of his distortion. The prognosis with epiretinal membrane surgery is excellent. 95 to 99% of patients have an improvement on their OCT or anatomical improvement. 70 to 90% of patients gain at least 2 lines on the Snellen chart. The vast majority of patients get a resolution of their distortion or metamorphopsia. 5 to 10% of patients, or 1 in 10 patients, can get an ERM again if they haven't had the ILM peeled. I'll talk about ILM peeling later on today, but the ILM peeling is something that we commonly do as part of the surgery that we offer. So the chance of recurrence with an ILM peel is only about 1 to 2%. So linking this back to the college guidelines, the College of Optometry guidelines say that patients whose vision has dropped below 612 or more than 2 lines from their baseline and or have distortion should be referred to a vitreoretinal service. So even if the patient has 6/6 vision, but is subjectively aware of distortion, potentially an accountant working on an Excel spreadsheet, will still offer them surgery. If their vision hasn't dropped and they don't have any distortion, they don't necessarily need to be referred. An annual monitoring in the community is absolutely fine. This guidance mirrors the guidance that was published by the Royal College of Ophthalmology, and which you can find online. And on the College of Ophthalmology website, they have this nice flow diagram which helps you with that decision making. Moving on to the next condition we're going to talk about, VMA and VMT, vitreomacular adhesion and vitreomacular traction. So linking back to what we're talking about, the stages of PVD. Stage 1 PVD, we get detachment of the perifoveal layers of the vitreous, which is what we see in picture A. This is basically vitreomacular adhesion. The vitreous is still adherent to the macula. And this is classified as focal or broad, depending on how broad the adhesion is. VMA is not really of any consequence, doesn't need any treatment or any special intervention. Problems happen when there's vitreomacular traction. Vitreomacular traction is defined as when as the jelly is being pulled off, it comes off, as it's coming off the walls of the eye, it's causing distortion to the retinal layers. Sometimes this can be quite dramatic, and the distortion that the gel exerts on the retinal layers leads to the symptoms similar to what we talked about already with epiretinal membrane. The traction leads to changes in vision, metamorphopsia, and distortion. VMT doesn't always need treatment. As we said, it can be considered almost a normal part of the PVD process. These slides are from a patient, again, who's come through our direct macular surgery pathway. She was troubled by some distortion in her right eye, which we can see here after stage 1 PVD. The jelly has come off adjacent to the fovea, but remains attached to the fovea, exerting some traction there. We didn't offer her surgery. We said we'd monitor this for a few months, and 2 to 3 months later, the PVD progressed, relaxing the traction exerted on the fovea, and her symptoms completely resolved. She still is under our clinic though, because she's got the same problem in the left eye, and hopefully this will relieve itself without any intervention. Sometimes, as I mentioned earlier, VMT can look quite dramatic. The traction the vitreous gel exerts on the retina can lead to massive structural changes. And sometimes that can lead to accumulation of cystic or fluid spaces within the retina, which is sometimes tricky to differentiate from CMO like you might see after cataract surgery. On the right side, if we basically, how do you differentiate the two? We look for clues on the OCT scan. The bottom one has a good clue showing that this is a VMT. What we're looking at is the posterior vitreous face. Here, you might appreciate it's pretty straight. It's not really pulling on the retina, but we've got these massive cystic spaces. And this is a case of CMO post-cataract surgery. If you compare that to the other picture, the vitreous is pulling. It's got a broad adhesion to the retinal surface, and it's pulling the retina upwards. This is a case of VMT. Sometimes it's difficult to differentiate the two, and a definitive test that we can offer in the hospital is a fundus fluorescein angiogram. The dye test essentially will leak when there's an inflammatory component, like in cystoid macular edema. You'd get this petaloid white appearance on the fundus fluorescein angiogram, whereas in VMT it would be completely dark. You don't get any leakage of dye with tractional pathology. Prognosis is very good for VMT. There's been a big study looking at VMT over 2 years. 60% of the patients stay the same with no change in the VMT at all. 20% of them, or 1 in 5 of them, resolve by themselves as the PVD progresses, like the patient I showed you earlier. And 10% of them, unfortunately, however, as the PVD progresses, progress into a macular hole, which is the next condition I'll talk to you about. 10% of patients don't want to wait longer than 2 years. They might have some symptomatic distortion that's bothering them, and they might progress to surgery because they're symptomatic from the distortion. They don't want to wait any longer, and we can offer them surgery. The caveat to that is surgery for VMT can be slightly risky, and some people say that the complication rates from VMT surgery can be higher because by definition you've got a slightly unusual and sticky vitreous, and that increases the risk of retinal breaks during surgery. So, full thickness macular holes. Full macular holes occur in about 8 per 100,000 people per year, usually between the age of 60 to 70, when you might expect the PVD to occur. As we've talked about earlier, when the PVD happens, it can pull on the Macular cells. And in this picture here, the Macular cell cone has been pulled out, resulting in a macular hole. It more commonly affects women, about 2 to 3 to 1. And the symptoms of full thickness macular hole are reduced vision, a blurred central patch, or distortion. And all of this is through the damage of the central retinal layers. If you don't have an OCT available, a simple test that you can perform on the slit lamp is the Watsky-Allen test. And you can use this to differentiate from potential pseudo hole. So you're not sure, is it a full thickness break? Is it partial thickness break? You essentially get the patient on the slit lamp, make a very thin, narrow beam, center your beam on the slit lamp coaxially, and you then hold up your Volk lens and shine the beam of light right on the patient's fovea. And you ask the patient, what can you see? A patient with a normal intact fovea will say, I can see a straight bright line. Whereas a patient with a macular hole, because of the defect, will tell you that the beam looks thinned, there's a break in it, or it's bendy on the sides. And that's a very useful clinical test that you can do just on the slit lamp to identify a macular hole. Macular holes are classified by two grading systems. The old system, which is the biomicroscopical findings that you'd see on the slit lamp. Stage 1, you get a yellow dot where the macular hole is about to form. Where the jelly is pulling on the retina, you get a cystic space forming, which gives you the yellowish appearance. As the cyst grows and progresses through the layers of the retina, it turns into a yellow ring. Eventually, the gel pulls further, ripping open a hole, which we call a macular hole. And that's a stage 2 macular hole. Stage 2 macular holes are small holes that are less than 400 micrometers across. Stage 3 are 400 microns or bigger. And stage 4 is 400 microns or bigger with a vice ring. And this is what a macular hole looks like clinically. The new classification system, which was set out by the International Vitreomacular Traction Study Group, is based on purely OCT findings, and it's much simpler. Basically, holes are classified into small, medium, or large, depending on their size, 250, 250 to 400, or bigger than 400. And to measure the size of a macular hole, you basically need to look at the minimum linear diameter. So you look at your hole in your OCT scan, you scroll through and find the biggest gap that you can find, and then use the caliper function on your machine to measure the smallest distance you can find between the hole. In this case, the hole is bigger here, but the smallest distance is across here. So we're measuring it at 223. This one has a different appearance. It's widest at the bottom, but the smallest gap is at the top here. So we take our calipers and measure across here the minimal linear diameter of 303. You'll notice in both of these pictures, you've got the PVD, the Muller cell cone is being pulled out, which you often see as a operculum clinically. The prognosis for macular hole treatment is also very good. We can achieve anatomical closure in 90 to 95% of patients with one operation. With 2 operations, the success rate goes even higher to 98%. More than 80% of patients gain more than 2 lines of vision. About 40% of patients will go back to driving standard. 80% of patients have resolution in their distortion. The chance of it happening again once it's treating is extremely rare, probably less than 2%. And I'll just mention that not all holes need surgery. In very small holes, which are stage 2 holes of less than 250 microns in width, 5% of patients can spontaneously close. I remember a patient once coming to theatre. We asked him which eye are we operating on you today, and the patient wasn't sure. And he was one of the lucky few percent whose hole spontaneously closed without a surgery. It's probably because as the vitreous gel continues to pull off, the macular hole, the edges of the retina act like a trapdoor. Where the traction's been removed, it can sometimes fall down and close the hole without any intervention. This is a progressive OCT scan of a patient who's had macular hole surgery. They have the macular hole. Immediately after surgery, we peel the ILM, allowing the hole to close, releasing the traction on the retina, and then it fuses together with progressive improvement of the outer retinal layers. I should mention at this stage, after ERM and macular hole surgery, vision can continuously improve even up to a year down the line. The goal of the surgery is to relieve the traction, allow the retina to fall into place and to mend, but there's a degree of recalibration at the level of the retina that can progress even up to a year down the line. So patients who might have some distortion, say 6 weeks after surgery, that will gradually improve even up to a year afterwards. So the college guidance, the College of Optometry guidance, treats VMA, vitreomacular adhesion, VMT, vitreomacular traction, and lamellar hole as non-urgent sight-threatening conditions, and make a recommendation for monitoring of these conditions with a routine referral if necessary. Full thickness macular hole is an urgent condition, class is A3. They require urgent referral within a week. The reason being is because I mentioned earlier, treatment of a macular hole when it's still small and quickly in under 3 months results in better outcomes. The College of Optometry makes a mention of myopic traction maculopathy. I'm not going to go into this in too much detail, but basically, in a highly myopic eye, the eye outgrows the retina. The ILM is a fairly rigid structure, and as the eye grows and gets bigger, you get a staphyloma forming, the traction from the vitreous and the ILM exert tractional forces on the retina, resulting in a multitude of presentations of basically all the conditions we talked about: retromacular traction, foveoschisis, or macular hole. Essentially, if you can identify all the other ones, myopic traction maculopathy is exactly the same, just in a very myopic eye. Something that's harder to deal with and something that I'm more interested in is dealing with larger macular holes and traumatic macular holes. Traumatic macular holes occur through injury to the eye. A blunt force injury to the eye causes anterior-posterior contraction of the eye, which exerts pressure on the vitreous, which can then pull the Muller cell cone that we talked about. Traumatic holes behave slightly differently to PVD-related holes, in the fact that 1/3 of them can actually close by themselves without any treatment within 2 to 3 months. If they don't close by themselves, however, they are a bit trickier to fix, as they tend to be larger holes and they need special techniques to close. So I thought I'd take an opportunity to talk you through vitreoretinal surgery using a case of a patient I operated on a few weeks ago. This patient basically, unfortunately, banged his eye as he was getting out of his car. He banged the car door against his eye, and he gave himself a very large traumatic macular hole of about 800 microns. So the patient comes in, we start off the surgery for him with a routine cataract operation. I won't bore you with this bit. We perform a capsulorhexis, crack the lens, remove the lens, clear the capsule, and inject an intraocular lens. Make sure the wounds are nice and watertight before proceeding with the vitreoretinal part of the surgery. Here's some top-up of anesthetic, and we then proceed to place trocars, which are basically little ports to allow us to do keyhole surgery to the posterior part of the eye. We place 3 ports. One of them is used to connect an infusion line, which keeps the pressure of the eye up with the fluid whilst we perform the surgery. We then use an indirect lens, which is connected to our microscope to see the back of the eye. This has an inverter, the microscope has an inverter in it, so that even though we're using an indirect lens, the image is flipped the right way around. And we use 2 instruments. One is the light pipe, which is illuminating the retina for us. And the right instrument is the vitrector. It's basically a tube-like structure with a little guillotine on the end, which cuts and shreds the retina as we move around and aspirates it, removing it. The vitreous is a clear substance. You can't see it, so we use the light pipe to indirectly see the vitreous. We appreciate the vitreous through its movement. Here I've put some dye in to help me see the vitreous a bit clearer. And when we perform a vitrectomy, we essentially go around and clear the vitreous 360 degrees around the retina. We then perform an indented search. We use an indenter to press on the walls of the eye to see the anterior vitreous, because very commonly with vitrectomy surgery, you can develop anterior vitreous breaks, anterior retinal breaks, which might lead to detachment. So we always do this check with every retinal surgery, make sure there's no breaks. And here we've identified a little break in the anterior retina. You might see a tiny round hole there, which is going to go bright white. There we're performing some cryotherapy. Cryotherapy is a special probe that freezes that area, creating a chororetinal scar to seal that break. So if you've seen a patient post-op who's had macular surgery, if you see some scarring in the peripheral retina, don't worry. That can be part of routine surgery. You don't need to worry that this patient has developed a new break or something like that when they've had surgery to their macula. It's a very common finding, and you can almost expect to find it. Once we've done that, we now know the retina is secure. We put some dye in to stain the internal limiting membrane, which is the top end of the Muller cells. Here, we're clearing the anterior vitreous to make sure the patient has no floaters, and we perform a surgical capsulotomy, cutting a little hole in the back of the bag so that the patient doesn't have to come back for a YAG laser capsulotomy. It also gives us a clearest view to do our surgery. Using these forceps, we then proceed to peel the internal limiting membrane, which is now stained blue with the special stain that we've used. In a normal macular hole, we'd peel the whole membrane off, but because this hole is very large, just peeling the membrane won't be good enough. We have to create what we call an ILM flap. So here we're peeling the ILM. It's a very thin structure. It's about 1/50th the width of a hair. So just pulling on that membrane exerts force on the retina, which can cause some of the capillaries to burst. So no consequence, that little bit of bleeding is actually helpful. Blood can help close macular holes. We peel the ILM to fashion a flap, which is like a trapdoor to close the hole. We then peel off the residual internal limiting membrane, relieving all the tractional forces that are pulling on our macular hole. And once we've got a nice clean surface, we reposition that flap so it's unfurled and nicely covering the hole. St. Thomas's, we benefit from an intraoperative OCT on our microscope, which allows us to directly image what we've done. I'll pause it gently here. So here, the OCT is across the macular hole with the ILM flap. And you might appreciate these are the edges of the hole, and this is the flap over the hole in the vertical and horizontal axis. This flap will then close and plug the hole, allowing it to dry out and allow the Macular cells to travel and join together and mend that macular hole and pull it all together. This flap is then supported with a gas bubble. For every macular hole surgery, we usually use a gas bubble, which presses on the hole or the flap, drying it out, giving an opportunity for the Macular cells to travel across and close the hole. Once we've created the flap, we fill the eye with air through our infusion line. We remove our ports. The air is very much acts like checking a bicycle tire for any leaks. If there's any leaks in the eye, it will bubble up. So here we're just doing a check to make sure our wounds are nice and watertight with no sutures. We then exchange the air in the eye with the gas. We're injecting gas through our infusion line. And using a needle, we're venting the air out so there's a complete exchange of air with gas in the eye. Finally, at the end of the surgery, we check the pressure. We tap the eye a little bit to check the pressure, remove the infusion line, and we then inject subconjunctivally a bit of steroid to reduce the inflammation, reduce the need for drops after surgery. We also give some antibiotic intracamerally. So sometimes though, even despite all these attempts, holes can persist. And there are a number of different ways of trying to fix them. Many techniques have been proposed. One new technique that we've been performing, which I'm quite proud of, is using Omnigen. Omnigen is an amniotic membrane. Women who have gone through pregnancy kindly donate the amniotic sac, which has enclosed their baby for 9 months. The amniotic membrane is then taken by the company, who dehydrate the amniotic membrane, and through a special process cleave off the stromal layers that make up the amniotic membrane to create a very thin membrane, which we can then use in macular hole surgery. In this video, this is a case of a patient who had uveitis, had a large macular hole. He had multiple surgeries abroad and had hand movement vision. We took him to surgery to try and see if we could perform some of the techniques that we've mentioned already. Unfortunately, the ILM was very weak, very bitty. We couldn't really use it. So here, using Helon, which is a hydrogel, we're opening up the macular hole. It was quite scarred and adherent, creating a little bleb or a little space that will allow us to treat the hole. We then take the amniotic membrane. It's like a flaky structure, which is dehydrated. We punch out a little hole. which we then take and fold to insert in the eye. There it is. There it's being folded up. We then insert it in the eye, unfold it. We can gently bring that membrane down into our hole to plug it. So it's sitting nicely there under the edges of our macular hole, creating a plug which will dry that macular hole, allowing the Muller cells, giving the Muller cells a scaffold to grow over to help mend the macular hole. Here we're exchanging the fluid in the eye with some air, and we drain all the fluid and put gas in like the previous case. So these are some post-op pictures from the patient. A large hole, 1,300 microns across. This white structure is the amniotic membrane, 1 week post-op. The gel that we use to open up the hole is absorbed by the RPE cells, and then the amniotic membrane integrates itself within the retina with proliferation of cells above and under the membrane. This can continue, the anatomical changes can continue to improve for years after the surgery. This is about 2 months after surgery. So you'll rarely come across this, but if you do see a patient who's had a macular hole who ends up with a white disc in the center of the retina, don't worry, it isn't a new optic disc, it's probably an amniotic membrane patch. Lots of people have tried all sorts of other things. People have tried detaching retina, cutting pieces of retina out and using that to plug the macular hole. But it does, whilst you plug the hole, this is the hole and this is post-op with a piece of retina shoved in the hole, it doesn't look very nice, and often the outcomes aren't very good. People have tried cutting holes in the macula to relax it. Quite traumatic. We don't generally do this. Professor Wong at St. Thomas's has the longest and biggest case series of this technique of retinal expansion, where we inject fluid to hydrate the retina, which will allow the macula to stretch and allows the retinal edges to oppose once we dry it, to allow the retinal macular hole to close. This is what we'd routinely employ after an ILM flap if it's failed. And if that fails, we would then proceed to a technique such as amniotic membrane. Finally, as I mentioned earlier, blood can also be used to close holes. In this case, the patient's own blood has been taken, injected in the eye, allowed to clot to create a little flap, which can then be used to close the hole. So to summarize what we've gone through today, I'll go through the conditions that we've talked about and just highlight some features on the slide. So picture 1 up here, top left, is normal. There's no PVD, normal looking retina. In picture 2, this is a stage 1 PVD. You can see the vitreous has started to detach perifoveally. The retina has no traction on it, and it looks fairly normal. That's stage 1 PVD, completely normal. This picture, difficult to know if it's VMA or VMT, but you have to carefully look to see if there's any distortion to the retina. There's a little bit of traction there. So this would be classed as a focal VMT. This one, you've got PVD, pulling on the retina, distortion on the inner layers. This is another VMT, but just a bit more dramatic. Next picture, we have a gap in our retinal layers. So this is a full thickness macular hole. Next one is partial thickness defect. Not much of a membrane on the surface. Looks degenerative. This is a lamellar hole. Bottom left, we have a membrane growing on the surface, a bright white membrane with some changes in our inner retinal layers. This is an epiretinal membrane, stage 3, because we've got tissue growing across the retina. Here, the membrane is pulling the retina outwards and zipping the retina, causing a schisis. This is ERM with foveoschisis. And here, the retina is being pulled inwards, giving a sharp drop, which we call a pseudo hole. So The take-home messages that I wanted to give you today is basically at St. Thomas's, we've set up a new referral pathway to treat all of these vitreomacular conditions. The pathway is a rapid access pathway that gives patients a consultant opinion within 3 weeks of referral, aiming to deliver surgery within 3 months. You should urgently refer full thickness macular holes and any other condition that results in a reduction of vision or distortion where no other cause is found. This is once again an overview of the pathway, as I mentioned. Primary care, identify the pathology, send it to the single point access, who divert it to the direct macular surgery pathway, which can be specified on your referral. And within 3 weeks, consultant opinion and 3 months to surgery. Thank you very much.
Thank you so much. That was amazing. And especially the videos. We don't really get much opportunity to see those sorts of things. So it's a real treat. So thank you very much.
I hope that was useful. It's what I get excited about, but I know it might be boring for you guys, but it's what we do day to day.
I am definitely in your camp on that one. Definitely very exciting for me. I'm just going to invite the audience if they have any questions. There's nothing in the chat. But I have had a few comments and thank yous and fantastics on the presentation today. I am going to, if there's no questions, I'm going to stop recording.